Welcome to PTEC's monthly webinar in our exploration of health equity issues facing our health system, especially with the COVID pandemic and its impact on our Latinx, Black, Native American, and Asian communities. The Preparedness and Treatment Equity Coalition brings together private businesses, researchers, and advocates to narrow health disparities through a focus on metrics and considerations on payment mechanisms. PTEC aims to study and identify these issues with specific focus on vaccinations, metabolic, and cardiovascular diseases. As part of our monthly exploration, we're lucky to have Dr. Brisa Hernandez join us today. Dr. Hernandez is the System Director of Population Health Engagement and Partnership at CommonSpirit Health, one of the largest health systems in the US, formed in 2019 from the alignment of Catholic health initiatives and Dignity Health as a single ministry. Dr. Hernandez received her PhD from the University of North Carolina at Charlotte, and prior to CommonSpirit, served as faculty member of the Family Practice Residency Program and Director of Community Health at Atrium Health. She brings a wealth of experience to population health to help inform the discussion on health equity issues facing us today. I'll hand it off to you, Sarina, to start the discussion with Dr. Hernandez. Sarina?
Hello, so I'm Sarina Gawuga. I'm Director of Operations here at PTEC, and I'd like to welcome Brisa Hernandez from CommonSpirit Population Health. And I believe you have a short presentation for us before we begin our discussion.
I do. Thank you so much for having me. I'm going to go ahead and share my screen. Let me know if you can see it. Okay, great. So again, thank you so much for having me. I'm really excited to be able to share some of my personal research that I've been doing over the last few years, particularly, as Dr. Xu mentioned, around some of the other determinants of health that are impacting our Latinx community. So I do want to start off as a general overview and level set to share with you all a few things. First, it's important to remember, and I know it's very clear to all of us, that the US cost of healthcare continues to increase, yet we have some of the worst health outcomes compared to many other countries. Also, in the past 15 years, much has been written in the literature about what really impacts health, and it primarily does happen outside of the clinical walls. And these are considered the determinants of health, or the social determinants of health, and it's a term that we've all become very used to at this point. But the work that I present today will argue that it is actually beyond the social, and that we need to be thinking about the structural, spatial, and temporal aspects. Also, from a geographic perspective, we also know that urban restructuring has been a defining force in shaping many US cities over the past decades. And the research also argues that it is differentially shaping the health of diverse groups of people in the spaces that are also changing over time. Lastly, I want to bring into the conversation the concept of new immigrant gateway cities, particularly in the southeastern United States. It's important to consider how these areas continue to have an influx of foreign-born populations from different countries and at different waves, and these populations themselves have different determinants of health. So there's a couple of things also to keep in mind when considering this research. Both of the character and dynamic of places where individual determinants come together and how those determinants and their interactions are changing over time may actually have more of a role to play in health than has previously been cited. And then second, I want to take the opportunity to explore the coincidence of a new Hispanic immigrant settlement along the South Boulevard corridor in Charlotte, North Carolina, as that area also undergoes various manifestations of restructuring, such as gentrification, revitalization, and upgrading. All this being said, it is critical to consider the process of restructuring that is driving the change in a particular space over time as health determinants themselves. In implementing this research, I did use a mixed method approach with an emphasis on the qualitative, which served both in the collection and the analysis of the data. And it's an opportunity to look at a complex and broad questions from different perspectives. I do also want to set the stage and share some information about the study area where I implemented this research. The South Boulevard corridor is located in Charlotte, North Carolina, which consists of 11 census tracts that you can see highlighted on the map, and they are clustered around what is the South Boulevard corridor. It's the second largest settlement area of Hispanic immigrants in this city. This particular corridor also has experienced similar growth patterns and diversification as other areas of the city that can also be described as restructuring. We also know that a light rail that was put in place in 2007 was a catalyst for much of this change. And we often know that new transportation gateways tend to do that. And it's resulted in businesses and residential trend changes over time, coinciding with simultaneous construction of a interstate around the center city, as well as revitalization that's occurring there, creating a very well-known lack of affordable housing in the area. In addition to those broader changes, there's been an influx of Hispanic immigrants over time. And when looking at these specific census tracts, we see that were even changes between the broader Hispanic population and the subset of Hispanic foreign-born. That being said, it's important to remember that there are even more differences when the data is teased apart for different subgroups of the population. Another implication of the mixed method approach is considering the positionality of the different participants. This research and many others have argued that the Hispanic population should not be considered a homogeneous. In fact, even with this sample, we have people from different countries that have been in Charlotte for a different length of time. On the other hand, none of the key informants that were interviewed lived along the South Boulevard corridor, yet many of them had direct experience working with the community members that are living in that area. Regardless, the feedback that they provided was more of their perception of the impact of the determinants of health for this group. So in the next sections, I'll be presenting some excerpts from the broader results section of my research to illustrate some of these main points. And I'm going to be focusing particularly on employment as a determinant of health that was described from the perspective of all four aspects by participants in the study. So here I provide a quote from a couple of community members that I interviewed. And so when we're thinking about how employment is a determinant across these various aspects, we can think about it structurally from the perspective of E-Verify, which is a web-based service that allows enrolled employers to confirm the eligibility of their employees to work in the United States. And although this is an optional program, we know that many large employers do implement this. And so you can imagine that for an undocumented immigrant group, this creates additional stress to being able to obtain jobs with any kind of benefit. Socially, it has created a sector of self-employment that is outside of the mainstream and likely not being tracked. And when we think about it spatially, jobs are not located near where Hispanic immigrants live. Instead, they're having to travel long distances, often outside of the city limits for work. And lastly, when we think about the temporal aspect, this has been a trend that has been increasing over time. Many of the participants that first arrived 15 to 20 years ago to the Charlotte area talked about how they did have a regular job when they first got to the area, but with the implementation of E-Verify, they lost the employment and lost employment and had to find other types of work. So employment is also a documented indicator of restructuring, but unfortunately, data on self-employed and unemployed are not available for the subset of Hispanic population. Rather, it's only available as a total population. There was a decrease in the proportion of residents of the corridor that were considered unemployed compared to the rest of the county, and this could possibly be explained by the influx of young professionals to the area that was described by a number of participants. As a geographer, I do want to include some of the geographic implications of the data as well. I implemented a LISA, or a local indicator of spatial analysis, and this was an opportunity to evaluate the clustering of the Spatial Association for Restructuring Factors found to be significantly associated with change in the proportion of Hispanic foreign-born population. And these factors included gender, high school diploma, and insurance status. I have chosen to share and focus only on the population to again illustrate the difference in clustering between them. So there's a greater low-high clustering of the Hispanic, so general Hispanic population on the east side of Charlotte, as opposed to a greater high-high clustering on the west side of Charlotte for those that are foreign-born. So this can be an indicator of how the Hispanic population is having to move to the outskirts of the county, which was also something that was mentioned many times by the participants. And that for those that are foreign-born, community members settling in areas that have not been part of that traditional immigrant settlement pattern for this particular county. So in summary, it was evident that through the conversations with community members and service providers, as well as the available data, that it's important to acknowledge the complexity and the intersection of the various aspects. Knowing the information allows decision makers and stakeholders to truly understand the population and its evolving needs. More importantly, data such as concentration of these indicators in the population is not enough to make decisions, particularly because of the lag and the gaps in what is available for those subpopulations. So it's key to take into account where and how the determinants are impacting health to be better prepared to implement interventions to address existing needs or potential needs that may arise for this particular population. And more specifically, for the Hispanic immigrant population that's living along the South Boulevard corridor, it was evident that they are impacted by the various aspects in different and intersecting ways. Socially, in terms of who and how they navigate the information they know about the system. Spatially, by having to be nimble and adapt to the changing environment, including where services are located or where they have to work. Structurally, because many of them are undocumented, and there are policies that impact their daily lives differently than those who are native born, as well as decisions are being made by policymakers that do not take their lived experience into consideration. And lastly, temporally, although many have been in this country and city for many years, their situation is unchanged, while everything around them continues to change. All of these factors are necessary to take into consideration when developing effective and sustainable interventions. So I do want to take a moment to reflect on my own positionality in this particular research because it is important to acknowledge. I am a non-traditional researcher and a community health leader. And as I was implementing this research, I was also engaged in community-based research with the Hispanic immigrant community and supporting the development of a community health division for a local health system, of which one of the strategic priorities was addressing the determinants of health. As an insider, I can speak to the importance of this work as it informs the growing trend of healthcare systems acknowledging what is happening outside of the clinical walls and integrating the determinants of health in clinical settings. Although care coordination and management has occurred within acute care spaces for many years, more and more attention is being put into how it can support the outpatient or the ambulatory space, in particular with implementation of interventions that are focused on determinants of health such as housing and transportation, which require better understanding of community members and the resources available. This type of work continues to inform healthcare reform and various aspects of payment models supporting the transition from fee-for-service to value-based care. And lastly, I was finalizing the discussion section, of my dissertation as COVID was starting to come into the picture in March of 2020. And many of us doing community-based work during that time, and especially those of us working with the Hispanic immigrant community, knew that if we didn't do something early, it was going to be really bad. And in other words, it should not have been a surprise, really, that certain groups, and particularly certain neighborhoods, would be impacted disproportionately by this virus. And so with that, this process has illustrated that the key to preparedness is both better data and proactively monitoring and engaging vulnerable populations so that health systems are better able to immediately mobilize and support those communities. Because I have been so integrally involved with members of and partner organizations supporting the South Boulevard corridor over many years, I was able to mobilize and get masks and other supplies and testing to that area, but that was only part of the support that was needed. And so we have to take the lessons learned from COVID and the information that we already know, acknowledge that there's the social, spatial, structural, and temporal aspects of the determinants of health, and do better. And that's the end of my presentation. You can go back to the discussion.
Well, Brisa, thank you so much for presenting your research. I think it's really fascinating, not only because I think a lot of people aren't, exposed to a field like demography, but also because we don't often talk about mixed methods research. And I think it's really critical when we're talking about these populations to have their viewpoints integrated into the research. So one of the questions that I have for you, and I think maybe other people have this question as well, is why do you think that, we talk a lot about the social determinants of health. That's kind of what we are saying over and over again, but you bring up these other determinants of health that are also critical in considering how to, approach health equity. So why do you think it is that maybe people aren't looking as much at the structural, the temporal, the spatial aspects of the determinants of health? Is it because it's more difficult, or it's just, it's not in the mindset of a typical researcher in this field? What do you think is going on?
Yeah, I think what's happened, and I will say I was spoiled pretty early on by working with geographers in this space, starting in 2009 when I was doing a lot of this research. And a lot of what they taught me and how I was trained was to think sort of beyond what's kind of put in front of us, right? And particularly around the data as it pertains to food, transportation. I mean, those are tangible, right? There's data available, you can speak to it. And we do speak to the fact that, tell me your zip code and I can, your zip code is more important than your genetic code. But I think we stop at that, and we don't take the time to really take a deep dive into what does that mean. Well, that means that this particular neighborhood has been changing so much that it's contributing to the fact that accessing healthy foods isn't easy. Having access to healthcare is made harder because an interstate was built around the neighborhood, right? Or some of those factors that happen over time, policies, this restructuring. And so I think that becomes a little harder. And honestly, it starts getting into some of those systemic issues that oftentimes we're uncomfortable bringing to light because we have relationships or we have things that are happening within our communities. We're not quite ready to go there. So I think it just becomes a conversation that gets a little bit hard. And again, it's easier to look at the data for there's not enough grocery stores in this neighborhood, but we don't take that other step to bring in other sectors into the conversation.
Actually, that kind of brings me to my next point. So, I think a lot of times I think of there's two things going on. There's sort of language and there's knowledge base. And so if we start moving into thinking more multidimensionally, not only social, but structural, temporal, spatial, that will sort of involve bringing in other professions into this discussion. So not only demographers, I think we're also talking about urban planners, perhaps architects, city planners, all of those different types of professions that we don't usually think about. So how do you think that we can bring those people into this discussion in terms of thinking about how we can approach health equity more globally? How do we get them to not only join us, but how do we explain why they're important to this effort?
Yeah, I mean, I think we have to look at COVID, right? I mean, any of these conversations that we're having around access to testing early on, now we're having access to vaccines, is an opportunity to open it up to these multi-sector partners that, to your point, have not traditionally been involved, right? And so how are we ensuring that we're setting up testing, that we're setting up vaccine sites in those spaces that are more conducive to some of these populations that have been traditionally marginalized, right? And so how do we engage them in saying, not blaming, but saying you maybe didn't think about this when we were, when you were developing this neighborhood, or not putting sidewalks into this particular area, or things like that, right? And saying it's an opportunity now to all come together to the table, break down those silos, because I think for many, many years and generations even, we've said, okay, you're an urban planner, so you think about space and you think about the urban space one way. You're a healthcare provider, you stay in the clinic and you give the medication, take the blood pressure, but we never really actually said, let's have this conversation together and how we're impacting each other, right? And so I think this is an opportunity, and we now know better, so we really do have to do better and use this as that time.
Okay, so then we'll move to another thing. You kind of leading me along to all my questions, actually. So I know you're at CommonSpirit now, and you're in their population health, and you're involved in community engagement, among other tasks that you have there. And so you've joined recently, right? Within the past year or so?
Yeah, I've been at CommonSpirit now going on 8 months, I think. So pretty new to the family.
Okay. So my question is, how do you think that your research will translate into your new position? Like, what will you bring with you into the work that you plan on doing at CommonSpirit?
Well, I mean, I can take a step back and say I was not planning to be a geographer. That's not what when I was little, that wasn't my plan. But I think as I've been in healthcare and exploring research from a lot of different angles, I really found myself thinking a lot about space and place and how people are interacting with it. And I've always been fascinated. Obviously, I'm a daughter of immigrants. And so for me, what it took my parents to leave Mexico, come to the United States, and what that created for the dynamic of our family, what that created for me kind of growing up. And so I think that it just provides that opportunity to healthcare, to have a geographer within a population health department, that opportunity to think beyond the clinical setting, right? To think beyond what can we do with this type of value-based contracts, or et cetera. We're actually going to open up that opportunity. And, I'm very fortunate to have this opportunity to join an excellent group within population health at CommonSpirit under the leadership of Dr. Nick Stein and his sort of vision of how, we need to think transformatively when it comes to this, particularly around how we serve the vulnerable populations. And my direct leader, Dr. Alicia Cole, is very open to this, right? She's a clinician, but she's also worked in the community space. So she knows that importance of the bridge or the translation between the community and the clinical. And so I think it just brings together all of these different skill sets, experiences, right? Both lived and professional, that we can hopefully use to support our patients and our communities that we serve.
So it's interesting that, this is a really common saying. You mentioned it earlier about zip code, right? But I think people have said it so many times, and I think you really kind of illustrated why the zip code is important. It's not just the number that, tells us this such and such information, but if you dig down as a geographer, as a demographer, dig down and say, this is why the zip code is important, because of redlining, because of the lack of sidewalks, the lack of green space, all of these different factors that fold into that. And I think that it's really important to have people like you in this discussion, people that we don't necessarily think off the top of our heads about who else could be useful for this. And so, you mentioned about, being a daughter of immigrants, I'm a daughter of immigrants as well. And, one thing that I always thought was fascinating is kind of like, how do you end up where you end up? Do you know what I mean? I mean, like my mother, for example, came here because she got a contract she's a nurse. She got a contract at a hospital in Michigan. I ended up in Michigan. That was the rest, that kind of laid this path for the rest of my life. And I think, you could say the same for your history as well. And so, I'm thinking about CommonSpirit and the, vast number of states that your system covers. And if the kind of research that you did where you're looking at a particular community and sort of their space and their place, how do you think that across your different communities, you can sort of take that general model and target a vulnerable community that's defined by a particular location? I mean, if you're looking at, say, the population you were at with North Carolina, you didn't have disaggregated, you didn't really have disaggregated data, but like, let's imagine that you did, you could target, you know, a Honduran community that arrived from, you know, this point to this point, so on and so forth. Do you sort of see that as something that could come along the line, like using this framework going beyond just social determinants of health, and using that framework to really target the interventions that a particular community needs, rather than how we're sort of thinking about it now, sort of more of a broad-based, you know, community-focused, without necessarily targeting it as much as we should be.
Yeah, well, and I think you bring up a few interesting things there. And one of the things to sort of kind of level set with is the data is one thing, right? And I mentioned it in my presentation. It's lagging. It's not available for certain populations. And so knowing that, that's why, and I'm more of a qualitative geographer, more of a human geographer. So I really bring in the importance of the voice and the lived experience. So and I didn't put this as much in this presentation, but I've often talked about the social determinants of health as actually being the lived experience, right? And so within the constraints of some of the things that have happened, the redlining and some of these other things, how are people experiencing those themselves? And how does that speak to how those it's impacting their health? But I think to the point of the zip code and being able to target, and let's say we did have the data as you were mentioning it, things are changing so rapidly, particularly as we're thinking about migration and immigration into this country, that we do have to take the time to actually go into that local context and understand. And I'll point out a really quick example. As we were starting to do this work in Charlotte, we have the data that shows where these settlement patterns are of Hispanic community, right? And we were getting ready to go into that community and start doing some interviews. Well, we started talking to folks and they said, well, that particular apartment complex is now a refugee community. They kind of look like us, and this was community members. They kind of look like us, but they don't talk like us. So you're not going to find the Latin American community, immigrant community in that particular apartment complex. And it was like, 250 residents, right? Then we came to find out that many were we had people from Burmese, that were getting resettled in that particular area also. So now we're having this traditionally Hispanic immigrant settlement area shifting into now more other countries and more global, if you will. And so that is important to understand. The data isn't going to show us that for about 5 years, right? Because of the lag that there is. So I do want to make a pitch, if you will, for that qualitative approach and really understanding what's happening on the ground, the lived experience, how people are interacting with their space and moving with it, right? And that's the other thing. We could target a community, but it doesn't mean they're going to get their resources and services there. Many communities will find, and community members will find a way to travel to where those resources are. And we saw that here in the Charlotte-Mecklenburg area. I had people from Rock Hill, South Carolina, which is about 45 miles from Charlotte Center City, traveling to a clinic, a free clinic at a local church, because they felt comfortable there, because they knew people that were going there. So we have to keep in mind that sometimes people are going to move, and we just have to be ready for that.
I think that's interesting. You brought up the lived experience. I think my qualitative research professor actually called it lived expertise. And I think that, again, speaks to what you've been saying about getting more qualitative data. I think we sometimes in healthcare research, there's a lot of people who are very quantitative, very data focused. I'll include myself in that group. But the qualitative information is perhaps the most up to date. if you will. Like you were saying, when you go into the community, you're talking to people, they're the ones that are telling you, oh, there's a shift. You know, you wouldn't know that if you didn't talk to them, right? And I think that you're making a pitch for qualitative research. And I think that's a really important part of this discussion, because we don't really know what people need unless we ask them. And, you know, this concept that you have, is new to me anyway, of the different dimensions, not just social, but temporal, structural, spatial. We don't really know what that's like unless we talk to people, right? And I think that, again, it's another pitch for, you know, going to the community, partnering with the community. You know, I think there's a tendency for people to think they're experts in a particular field, but people who are living the lives are the best experts and the best people to talk to. So how do you think that we can get more people involved in actually doing community-based research? So not just people who kind of went into this field to do that work, but maybe people who have been more heavily quantitative, maybe are questioning, how do I break into this in the first place? Like, I don't know where to start.
Yeah, well, I think it's opportunity to, you know, if we look at it from the clinical setting, if you will, the clinical space, it's an opportunity to bring in your clinicians, your registration staff, et cetera. Let's talk about the experience that you're having in engaging patients. And if we talk about where your patients are coming from, what is their home zip code, if you will, because we have that data. Tell us about what you're noticing, right? Engage them in that opportunity to share their experience. And then I would also advocate for more opportunities for our patients to provide their feedback within, you know, patient advisory councils or things like that, where you're bringing in the voice of the patient in different perspectives. And then also within healthcare and a healthcare system, how do we have some of our infrastructure support each other, right? We have, at CommonSpirit, we have a community health department that is very engaged in the community at the facility level. They have many community partnerships. Well, as population health, as a clinician, I want to make sure that there's that constant contact with them, right? Because they're engaging on the ground in a different way than I can now that I'm at a population health level, if you will. And so how are we within our own system breaking down some of those silos and bringing people together in different ways? And we just had a paper published around what we're calling the Vulnerable Populations Council, where we brought in different functions, if you will, of our health system to think more broadly around what does it mean to care for vulnerable populations from a physical, a mental, and a social well-being perspective. And then how do they inform leaders across the system to help develop that strategy? So I think there's different ways that you can bring different expertise together to be able to speak to this. And it is that opportunity to have that uncomfortable conversation, if you will, to start getting things rolling and things changing.
Yeah, I think that's a really important point, and I think we talk about it a lot, breaking down silos. But you know, I think with an organization like CommonSpirit, where you have so many states, so many populations, and really a leadership that's driven to do this work, I really see that there's a lot of value to have, including people like geographers, demographers, who aren't traditionally included. And I really appreciate that you have brought your work to us to show us the value of bringing more people into the discussion. And I hope that, you know, we continue to include more people who have different areas of expertise that maybe we talk about but don't really think about including. So I really want to thank you for coming, and I know that we're going to be working with you again in the future, and I would love to hear, you know, at some point more of the work that you are doing at CommonSpirit and how you're bringing the research that you've done on not only social determinants of health, but also the temporal, spatial, and structural aspects, how you're bringing that into your work at CommonSpirit Health. And, you know, also as you said you published something recently. So also helping the rest of us think about how we can include those other dimensions in our discussion about how to reduce health inequity. And so with that, thank you very much for coming. Thank you for all of our viewers for joining us. And our next webinar will be in May, date to be determined. So please go to ptechhealth.org/events to find out when the next episode is coming up. So thank you, Brisa.
Thank you so much for having me.
Okay, bye.